Today we will be talking about the brachial plexus and the supraclavicular nerve block. First, let's start out with some information about peripheral nerve anatomy. Nerves are a collection of axons surrounded by the endoneurium. Fascicles are a collection of axons surrounded by the perineurium. And then the nerve fascicles are separated by connective tissue and surrounded by another layer of epineurium. Local anesthetic is injected adjacent to the nerve, so outside of the epineurium during a nerve block. The local anesthetic then diffuses through the membranes into the nerve cells. The brachial plexus is a bundle of nerves that stem from the nerve roots in the cervical and upper trunk sections of the spinal cord, C5 through T1. The brachial plexus creates a network that connects the nerves in the arm. These nerves control the motions of your wrists, hands, and arms, allowing us to do things like raising our arms and typing on a keyboard. The brachial plexus nerves also extend to the skin and therefore provide sensation as well. For instance, they let you know if a pan is too hot. Here is a drawing of the brachial plexus structure. As you can see, it is quite complex. Starting from the right, the C5 to T1 nerve roots emerge from the spinal cord and divide into trunks, shown in red in the diagram, into divisions, which is green, cords, which are orange, and then finally nerves. The terminal nerves are the musculocutaneous, axillary, median, radial, and ulnar. There are also other nerves that come off of the brachial plexus, but we will focus on these 5 nerves for this lecture. These terminal nerves provide both motor function and sensation to the arm. Here is another image of the brachial plexus. The brachial plexus can be blocked anywhere along its pathway into the upper extremity. They're typically categorized into 4 different blocks based on where the block is placed. At the level of the roots, at the top, a block there would be called the inner scalene block. And the little diagram at the top with the shaded blue shows the area that the inner scalene covers. Inner scalene blocks are great for shoulder surgery. At the level of the trunks, you have the supraclavicular block, which is the one we will focus on in this lecture. This block reliably covers the entire arm. It does not cover the shoulder. So it's good for arm surgery, forearm surgery, and then anything in the wrist and hand. The infraclavicular block is done at the level of the cords, and then finally the axillary block is done at the level of the terminal branches. Here is a table with a reference for what the nerves control. So briefly, the musculocutaneous nerve controls arm flexion at the elbow. The median nerve controls forearm pronation, wrist flexion, and thumb opposition. The ulnar nerve controls ulnar deviation of the wrist, little finger flexion, and flaring of the fingers. And then the radial nerve controls wrist and finger extension. Knowledge of anatomy of the brachial plexus and the origin and courses of its branches is key to selecting a block. This chart here summarizes which regions should be expected to have satisfactory coverage and which regions may be missed. For example, let's go over inner scalene again. It's great for shoulder and proximal humerus surgery, however, may miss the hand. Supraclavicular block, on the other hand, has great coverage for the proximal humerus and below, but will most likely miss the shoulder. Now let's focus our attention to the supraclavicular nerve block. As stated earlier, the supraclavicular nerve block is great for arm surgery distal to the shoulder. Includes the arm, forearm, wrist, and hand. We do not recommend using the supraclavicular block for anything that involves the shoulder. An inner scaling would be much better suited. The image on the right shows what the supraclavicular nerve block covers. As you can see, it covers most of the arm. However, the medial aspect of the proximal arm may not be covered, and you need an additional injection called an intercostal brachial nerve block. We will go over this later on in the lecture. The supraclavicular nerve block blocks at the level of the trunks of the brachial plexus. Here's a detailed image of the nerves that the supraclavicular nerve block covers. As you can see, the supraclavicular block covers most nerves of the arm and misses mostly the shoulder nerves, and then that medial inner aspect of the upper arm, which I mentioned in the previous slide. Let's look at the supraclavicular nerve block nerves in relation to the other anatomy. At the supraclavicular fossa, the brachial plexus and the subclavian artery lie above the first rib and the pleura. The brachial plexus, drawn here in yellow, is located lateral and posterior to the subclavian artery. This blue arrow indicates where you are blocking during this nerve block. Let's talk about the risks of the supraclavicular block. There is a risk of pneumothorax, although quite low, which is when you accidentally puncture the lung. The lung is very close to where the supraclavicular nerve block is done. The risk of pneumothorax is decreased with use of ultrasound. Phrenic nerve block can also occur during a supraclavicular nerve block, although you mostly hear about this during the interscaling block. The phrenic nerve innervates the diaphragm. Blockade will cause unilateral diaphragmatic paralysis, which is usually asymptomatic in patients with healthy lungs. In patients with severe lung disease or morbid obesity, a phrenic nerve block can present with shortness of breath, hypoxia, and distress to the patient. Treatment would be to administer oxygen and observe. In some cases, the patient may need to be admitted or even sent to the ICU. Horner syndrome can occur with the supraclavicular nerve block. That's due to blockade of the stellate ganglion, and you get symptoms such as ptosis, meiosis, and anhidrosis, as shown here in this photograph. And of course, as with all nerve blocks, there's always a risk of nerve and vascular injury. Again, risks are low if the proper precautions are taken and ultrasound is used. Quick question. A supraclavicular nerve block covers all parts of the upper extremity except shoulder, wrist, hand, or forearm. The answer is shoulder. Next question. A 30-year-old man is undergoing wrist surgery. During needle manipulation for a supraclavicular brachial plexus block, the patient begins to cough and complain of chest pain and shortness of breath. The most likely diagnosis is last, pneumothorax, angina, or heart failure. The correct answer is pneumothorax. Let's talk about patient and transducer positioning next. The patient should be supine with their head turned away from the side you're blocking. It can also help to elevate the head, which reduces the venous pressure, since you're also very close to some major vessels like the EJ during this block. For the probe, it should be positioned above and parallel to the clavicle in the supraclavicular fossa. To find the correct block window, you often have to aim the probe caudally down towards the feet. Take some time to scan to identify the subclavian artery and the nerve plexus. The ultrasound should be placed on the contralateral side that you are blocking, so on the opposite side of the bed. or in whichever position gives you the best patient positioning and ergonomics. Let's go over how the ultrasound anatomy looks. Here's a drawing of what the supraclavicular fossa looks like under ultrasound. The subclavian artery and the brachial plexus lie above the first rib. The brachial plexus is located lateral to the subclavian artery and appears as dark round structures like a bunch of grapes under ultrasound. Keep in mind that the lung, labeled here as the pleura, is also next to the rib and is hyperechoic, meaning bright. You may also see lungs sliding. Here's what the block looks like under ultrasound. So that's the subclavian artery, brachial plexus, the rib, and then the pleura. When you're doing this block, you should be able to have all 4 of these structures in your view before you start. This blue arrow indicates the path that your needle will take when you are doing the nerve block. Let's look at another ultrasound image. Keep in mind here that the orientation of the image has changed. Whereas lateral is now on the left side of the screen. Let's name the structures. Here's the subclavian artery, brachial plexus, rib, and pleura. And here's the proposed path that your needle would take. When inserting your nerve block needle, it is important not to transect the brachial plexus. You should aim to go below the brachial plexus and aim for the inner corner of the plexus adjacent to the subclavian artery. This gives you the highest rate of success. Sometimes you will need more than one needle pass to ensure that local anesthetic surrounds the entire plexus. So you may have to withdraw your needle a bit and then redirect to cover over the plexus. Remember too that multiple passes increases the chance of having a successful nerve block, but also increases the risk of nerve injury and inadvertent intravascular injection. Remember, this area of the neck has a lot of vasculature. Here's another example from Nysora of a supraclavicular block. The 2 white lines indicate the needle path. This is what the spread of local anesthetic should look like after injection, depicted in blue. This is what the block would look like after just 1 needle pass and 1 injection. While the brachial plexus is not as surrounded by local anesthetic as in the prior image, it doesn't necessarily mean the block won't work. It just may take more time for the local anesthetic to diffuse and cover the entire brachial plexus in this block. Let's walk through another series of ultrasound images of the supraclavicular nerve block. With this first image, the needle has been inserted and is advancing towards the brachial plexus and the subclavian artery. The image on the right shows that the needle passes below the brachial plexus nerve sheath into the inner corner next adjacent to the subclavian artery. The left image here shows injection of local anesthetic after the needle reaches the correct location. In this block, the operator readjusts the needle and makes a second pass above the brachial plexus to fully surround the plexus with local. And here's the final picture after injection of local. You can see that the hypoechoic local anesthetic surrounds the plexus very nicely, and the brachial plexus appears to be floating. Remember to always do incremental injections and aspirate every 5 milliliters when doing nerve blocks. Before doing a nerve block, you should also use Doppler to check for any vasculature in your projected needle path. The dorsal scapular artery and other vasculature commonly passes through or nearby the brachial plexus at the level of the supraclavicular fossa. The picture on the right shows the dorsal scapular artery going over and maybe through the brachial plexus. Make small probe adjustments, tilting and sliding to optimize your image, and look for a window where there's not vasculature in the way. Here's an ultrasound image of the supraclavicular block with Doppler. You can see here that the Doppler is highlighting the dorsal scapular artery. You want to adjust your probe at this point and look for a window where this artery is not in your needle path. Here's an ultrasound image with Doppler just showing the subclavian artery. There's no other vasculature lighting up. Which artery traverses under the clavicle and above the first rib and is one of the landmarks of the supraclavicular nerve block? Axillary artery, subclavian artery, carotid artery, radial artery. The correct answer is subclavian. Let's talk about a surgical block versus a block for analgesia. For a surgical block, it means that the surgery can be performed without additional anesthetic. Often, though, we still give some IV sedation to keep the patient comfortable. They do not need to be placed under general anesthesia most of the time. To achieve a surgical block, you need a higher concentration of local anesthetic, such as 0.5% bupivacaine or ropivacaine. The arm will be almost completely numb or completely numb, often with loss of motor function. For the analgesic block, it's done for pain relief. You can use a lower concentration of local anesthetic, such as 0.25% bupivacaine. The patient may or may not have loss of motor function, should have a lot of their pain resolved, but still will have some sensation. For either block, 20 to 25 milliliters of local anesthetic can be used. Let's go over the intercostal brachial block. If required, the intercostal brachial nerve block can be performed with a subcutaneous injection on the medial aspect of the arm, just distal to the axilla, shown here. This is the cover, the portion here of the arm highlighted in green that will often be missed with the supraclavicular nerve block. This intercostal brachial block works well for tourniquet pain associated with the medial aspect of the arm. You only need about 5 milliliters of local anesthetic, and you don't need an ultrasound to perform this block. You just do a giant skin wheel just distal to the axilla. Summary: we talked about brachial plexus anatomy and the different terminal branches, and we focused mostly on the supraclavicular nerve block. Remember, the indications are surgery below the shoulder. When you are doing this block, when scanning with the ultrasound, it's important to have the brachial plexus, subclavian artery, rib, and pleura in your view before you start. Always use Doppler to look for vessels in your projected needle path. And for a surgical block, you need 20 to 25 milliliters of 0.5% bupivacaine.